Brain metastases are a growing problem in the oligometastatic world, and in cancer in general. There are probably 150,000 people a year affected by this, although not all need treatment. And lung cancer, breast cancer, and melanoma are really the most common players in this field, but any sort of tumor can metastasize to the brain. Fairly typically, the lesions are small. They're often, but not always, located at the gray-white junction. MRI remains the best treatment for these. This is a fairly typical looking lesion. And we're not always right. Even when we have a patient with lung cancer or breast cancer who has a brain lesion, some studies show as much as 10% of the time the pathology of things that even look typical for metastatic disease will be something else, like primary tumors or stroke or infection. These are what I think are really the key questions that we're dealing with in the brain metastasis world. What's the true prognosis for the patient? What's the role of radiosurgery? And Joel has really touched on that. How do we choose between open surgery and radiosurgery? This is really the one that has us talking and sorting out is when to give whole brain radiation. And I'm going to spend a majority of my small amount of time on that today. And then later we could get into what's the future of systemic therapy for the brain treatment. So let's deal with prognosis for a minute. This is a paper that folks often refer to, really nice work from the RTOG and Lori Gaspar, looking at prognosis for a whole group of patients on RTOG studies with brain metastases. 3 classes. The class 1 folks were the most favorable: young, good performance score, very limited disease. The class 3 was everybody with a low performance score. And you can see even in the class 1 group, the prognosis is really poor, 7-month median survival. But we all see patients who do much better than that. And so I think this was a wonderful first piece of work, but there are really more refined data to look at. And so this is a really outstanding study, I think, published in JCO earlier this year, looking at 4,000 patients with brain metastasis and creating this sort of GPA score. It's not your grade point, but your graded prognosis. So they broke it down by tumor type, and I've shown the main table here: lung cancer, melanoma, breast cancer. So you go to whichever table works for your patient. Here's the breast cancer table, for example, and you see I've put 2 sample patients, one in yellow, one in red below. A patient a little younger, maybe 50, 55, with a HER2-positive tumor and a good performance score, and then a second patient with a basal type or a triple-negative tumor, a little worse performance score, and maybe in their early 60s. And if you sort of graph these 2 patients out, you see one has a score of 3.5 and one has a score of 1. Then you go to the second big table, and it turns out A is for breast cancer, so we look at the A curve. And if we plot those 2 patients who really don't sound all that different in terms of age and performance score, the difference in median survival is 2 years versus less than 6 months. And so I think this is a good study that really asks us to look at individual tumor type, when available to look at tumor subtype, and to use that to better predict prognosis. We might make very different recommendations for these 2 patients based solely on this prognosis. So this is a very useful table for doing that. Now, how do we go about treating these patients? Well, first, symptomatic management. So if they have edema or symptoms, steroids are appropriate. We give anticonvulsants primarily to patients who had seizures, not to patients who have tumors. So if there's no seizure history, we'll often hold anticonvulsants. Then we want to stage extracranially, and then we get into the treatment options. So I think about treatment like this, and I just put this into, although we're looking for cures in a small subset of these folks, with rare exception, most of this treatment remains palliative. And maybe Lance did so well because he was on some other medication his doctors weren't aware of. Just a conjecture, no proof of that. So here's a example of the way that I think about treatment. I hope this slide's going to project well. But the first treatment when brain metastases are discovered, if we don't watch, is usually either surgery, radiosurgery, or whole brain. But often these are coupled with other therapies, so we may follow that with one of these additional therapies. And so you end up with a total of maybe 10 different treatment options. It gets very complex very quickly. And there's theoretically ways that you could land in any one of these 10 boxes based on the particular case that you're dealing with. Sometimes the disease tells us what to do. So that big tumor on the left is very likely to be removed surgically, and the multiple lesions you see on the right are more likely to be treated with whole brain radiation or systemic therapy. And it's the one in the middle that really generates the most discussion, and we'll come back to that. So what about open surgery versus radiosurgery? So We usually move to open surgery if we have an unknown diagnosis, so a patient who with no prior history of metastatic disease but with a history of a primary tumor may well come to surgery if that's the best place to get tissue. Patients with big tumors or very symptomatic are more likely to come to surgery. And those who've had recurrence after a radiation-based strategy may not follow up with a second round of radiation. They may be more likely to come to surgery as well. This is what you might see. I always sneak this in right before lunch. So this is a pretty typical view of the brain here. This is a tumor here. This is slightly angry but otherwise pretty normal looking brain. And when we operate on a metastasis, we expect to get a pretty good resection. So you can see here a nice tumor cavity and the brain looking a little more happy already, even in the middle of surgery. We use image guidance, intraoperative monitoring, when necessary, intraoperative imaging to do this. And you can see the patient on the lower right there, a small incision with a pretty short hospital stay. I'm not advancing. Can you throw me forward one? Perfect. Thanks so much. Mortality about 2 to 4%, length of stay in the hospital about 2 days on average, and pretty rapid resolution of symptoms. So this is a good treatment in the correctly selected patients. Now in the last couple minutes here, let's talk a bit about whole brain radiation, because this is really the most burning question in the brain metastasis field. So it's been studied. Here's an example of a study, a relatively famous study from Roy Patchell and his group, where they compared two groups of patients. My box 1, which is surgery and then observation, versus box 6 in my table, which is surgery followed by whole brain. So their treatment schema looked like that. About 100 patients, everybody had surgery. That was the entrance into the study. And then they were randomized below to no whole brain or above to whole brain, and then they followed for recurrence patterns. And there was a very striking difference. So the bars in red represent the patients who did not get whole brain. The bars in yellow are those who did. And if you look at the overall recurrence, which is here, you can see a very striking difference in recurrence rates. And if you look at the second group there, it's recurrence at the surgery site. So 10% recurrence with radiation versus 46%. Now these are the most striking differences that have been shown in any study like this. And there have been some other studies that aren't quite as rigorous or frequently quoted that show not quite as dramatic a difference. But whole brain radiation is a powerful treatment and it works. The question is does this translate into a better outcome? So in this same study, there was no statistically significant difference in survival, although a general trend that way. And there was no difference in the functional independence or functional survival, if you will. And so people arguing in a particular case against whole brain will tend to focus on this slide, and those arguing for it will focus on the slide before. Now, what's the cost of giving patients whole brain? Well, it's a powerful treatment. Most patients tolerate it very well, but there have been questions raised about the cognitive side effects, and I'd say the jury's still out. This is probably the most current study that suggests that there is at least a transient significant cognitive side effect. So this is work out of MD Anderson looking at patients who had either radiosurgery, as Dr. Tepper showed, alone, or radiosurgery followed by whole brain, and then looking at the incidence at 4 months, just at a single time point, of memory and learning difficulties. And you can see there was a significantly higher rate of neurocognitive dysfunction at 4 months after treatment with the addition of whole brain. So this is certainly brings us to the discussion about the role of all of this. And so then we ask, if not everybody's going to get whole brain, should we add local therapy? And this is sort of where I want to end. So I showed you from the one slide that the local recurrence rate after surgery alone could be as high as 46% in one study. So what about adding additional local therapy? So see CyberKnife or Gamma Knife, which is the machine up in the center there. These have been used to give a boost to the surgery bed to prevent recurrence. These are other local radiation strategies. This is the local chemotherapy that I mentioned, and we just completed and are submitting a manuscript on a study that took patients to surgery and then treated them with local chemotherapy. And we followed neurocognitive outcomes, could actually show over the months and up to a year afterwards improvements in neurocognitive functions for the patients with a surgery with local chemotherapy approach, but without whole brain radiation. So certainly feeds this discussion. So let me stop with the background information and jump right to our case discussion. So the first of these three cases that we'll discuss is a young woman, 38-year-old, with HER2-positive breast cancer. She had a T3N1M0 tumor at diagnosis. Those things mean nothing to a neurosurgeon, but I'm assuming all of you know exactly what they are. Later, I'll ask Dr. Moss, he'll explain it to me. So the patient had neoadjuvant chemotherapy, AC, followed by taxane and trastuzumab, and then went on to radiation and surgery for her breast disease, and then a year worth of trastuzumab. She then presented a couple years later with a seizure and a small amount of left-sided weakness. Her neurologic exam, or left-sided numbness, and her neurologic exam was pretty normal, so she looked good. She had a bone scan that showed a couple of bone lesions that had not been picked up before, and she went to an MRI scanner. And this is her MRI. So we're looking at contrasted MRI scans here, an axial and a sagittal, and you can see the lesion here, cystic cavity, this is cyst, and then a solid tumor nodule, and the same image here. This is all swelling. This dark is all swelling around the tumor. So about a 2.5 centimeter tumor. And so we cannot stop and ask ourselves what would be the right treatment for this patient. And I've just listed 6 of the 10 different options. And, a surgery to remove that lesion, I might go back, whole brain, radiosurgery, or a combination of those, or systemic therapy. So let me put my colleague, Dr. Tepper, on the spot as today's king of radiosurgery and ask him how he would proceed in treating this patient.
Well, the first thing you want to know is whether you're sure you have the diagnosis. And so it sounds like there's maybe a teeny bit of uncertainty in this situation. I don't know how much, and that the patient has not been formally diagnosed as having metastatic disease. There are also the question of would it be useful to have tissue for molecular markers and the like that would make going in and doing a surgical approach reasonable.
So let me say that one of the bone lesions was able to be biopsied. It made the diagnosis of metastatic cancer. So we had that answer.
Okay. So then I think there becomes the question when you're treating the local is whether you have pressure effects that you want to relieve, and whether you have a surgically accessible area, that's a question that I then usually push back to you and say, is it something you think you can do well with surgically, and are there neurological symptoms that would be helped by some surgical procedure?
So I'll tackle that. So in the actual case, the great thing about the case is you can make it whatever you want as you stand here. But for this particular patient, we didn't have the diagnosis. There were not other lesions. And so we resected that lesion. And she did very well. She went home the next day, and we made the diagnosis. And she was not very symptomatic. So it was really the need for tissue that drove us to do surgery. But if we had tissue and she wasn't symptomatic, I think radiosurgery would be a very good option for her.
So I think radiosurgery is a good option, and it's something that can be done, and I think with good level of local control.
Now, if we'd removed this lesion, as we did, so now we have a woman, the lesion is removed, we thought the surgery went well, but remember, we're careful with margins in the brain, right? You have visual cortex here, you have sensory and motor cortex here, so the thought of a 2 centimeter margin is not going to be possible. Would you consider additional therapy for her post-surgical resection?
So this is an area that's, I think, very controversial. It's really hard to know what the right answer is. You can get local failure in this area, as you've already shown. I think there's enough information saying that one could use a radiosurgical approach to decrease the local failure rate. She's also at risk for failure elsewhere in the brain. And whole brain radiation could help that, whereas a radiosurgical approach would not. But she's also a 38-year-old woman who, I don't know what the rest of her social situation, but the neurocognitive issues, which I think are impacted to some extent by radiation, can be important. And lastly, there's the issue, is there felt to be any urgency in getting going with chemotherapy for other metastatic disease and the like? To be honest, I don't think there's a right or wrong answer to that, and I think people have different approaches, as you've already suggested, depending on what endpoint you're really looking at for this patient.
So if pushed to make a recommendation to her, what would you do?
I probably would do radiosurgery to the bed in this patient.
And I think that's the approach that I would probably take. But just as a last slide on this before we go on, let's make things a little more complicated. Let's say that she had a second lesion that was picked up at the same time. So there's a little lesion here. Thank you so much. That's perfect. And so now she has two lesions, not just one. And let's say that we decide not to do surgery because we have tissue diagnosis and she's not symptomatic. Would that convince you to offer her whole brain? Would you go with radiosurgery alone? How would you tackle this?
Well, what I probably wouldn't do in this situation is do no radiation, because I think with another lesion there, I think you want to do something, and you can have the option of whole brain or radiosurgery to both lesions. Again, I don't think the same issues. I don't think there's a true answer to that. If you start having multiple lesions, it becomes easy. When you go 1 second smaller lesion, I might still be tempted to use 2 radiosurgical approaches. Probably any more than that I wouldn't.
Got it. Very good. So are we inviting audience participation, or how are we doing this?
Yes.
Are there any questions or comments or different opinions? All right. Well, I'm going to go back and sit daintily on my stool, knees slightly to the left, hands folded. Thank you very much.
So Matt, how would you approach that last situation?
A lot of discussion with the patient, and I find they often have their own notions about what they want to do, so it almost matters less what we do. I'd be willing to treat the 2 lesions with local strategies for each with very close follow-up, but I think there's a pretty good chance the 3rd and the 4th may come along, and when they did at some point pretty close to that, I would say, okay, now we need a global strategy. Good. Thank you all very much.